I'm going to talk about global health because I think, as we are seeing with world events and definitely the pandemic, we are all very much connected. And so the idea of global health is how do we work together? How do we work together to make sure everybody everywhere is healthy? And this is a very nursing thing. So I really like the idea of global health. And I became interested in global health because as a student, I went and I studied in Mexico, in southern Mexico, and I got to have an internship in the health system so I could see what the health system was like there. And so I got interested in nurses and wondered why is nursing different? Because some things were the same, but there were other things that were not the same that you couldn't just explain by, not enough money, right? So that started me on my journey to doing work internationally. But global health itself is actually a field of practice and study and research. And the idea is that whatever you're doing, you're working toward improving health and achieving health equity for all people worldwide. So, already what you're doing, whatever you're already doing global health. Because even if you're working domestically, you're helping the health of your people, you're still good. You're still doing global health. So, what are the origins of global health? So, global health kind of started with colonialism. So, people coming from one place who had more power and economics and resources going to another place, imposing models of healthcare, organizing things in ways, taking away indigenous ways of knowing about how people heal and their spirit and their whole health needs. And so that was sort of the 19th century, part of the 20th century aspect of global health. And then we see professionalization. So if you remember your nursing history, nursing began to organize as a profession really around 1920, the early 20th century. And the idea was that, this idea of a professionally educated nurse was going to be a very important thing. And so nurses started to organize. They started creating nursing organizations, but they also took those ideas about nursing organizations to other countries and, places where women often didn't have a job that was acceptable to work in outside the home. So nursing would become a job that was acceptable in many countries for women to work in outside the home. And so that started us off. And then world wars happened. And when we look at war is bad for your health, current events, no exception. um, so world wars really pushed global health because we realized that if a whole world war could affect the world, what could we do for good afterwards? So this is when we start seeing the creation after World War II of international institutions like the United Nations, like the World Bank, the International Monetary Funds. And the idea behind these institutions was they could help countries build infrastructure faster than if they were paying for their own resources. Now, that creates its own set of problems because many countries have so much debt that they are not allowed to spend as much as they need to on their health systems. So that, becomes this sort of vicious cycle. And, the financing systems think that things should be done in a certain way. So in the 1980s, a lot of these financing systems were telling countries, well, you have to decentralize and you have to operate your health system this way in order to get money from these financing mechanisms, which, well, like everything, it has its pros and cons. Oftentimes it can be very negative. But what happened with those financing changes was HIV was also coming onto the scene. And in many countries, HIV devastated the health workforce. I mean, countries literally went from having enough health workers to having none because they had died. So that is a real problem if you're trying to have a stable health system and build up your health overall, the health of your people. And then economists, it took them a really long time to figure this out. Economists started figuring out that, oh, wait, countries with healthier people had better economies. I know you're shocked, right? Of course they do. So they started seeing this link between economics and health. And so this is when we start seeing more and more attention being paid to human development. How do we help people become healthy so they can live the life that they want, whatever that life is? And this includes people who have disabilities, who have other challenges, just giving people to live the opportunity to the equal opportunity to live the life that they want. And the general consensus was, well, poverty is bad for a lot of things. Poverty is especially bad for your health. So global health up until then, most people were working in it out of the love. There was no money. There was minimal grants. A lot of times it was people working in infectious diseases. So it was HIV, but it was also malaria, TB, all of the other ones that are out there. And then the Gates Foundation comes along. And so the Gates Foundation comes along and they basically they put the money into the field of global health. And all of a sudden, this was a whole new world. At the same time, other philanthropic ventures started funding global health. So international NGO, non-governmental organizations, countries, researchers all had access to funds finally. So it was amazing. And I was just coming up. So I fell in love with global health in the mid 90s. And so I watched this evolution and there it was, boom, there was money. And all of a sudden it was like, whoa. It's like, wait, I'm not crazy. Because most of my American nurse friends were like, why are you doing that? It's like, but we have problems at home. I'm like, no, 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 it's all connected. I couldn't explain how it was all connected then, but I can now. So the goals of global health is that we're systematically addressing issues and concerns that transcend national boundaries, and they require international collaboration to solve. The COVID pandemic, great example. This was way harder to explain before COVID, much easier now. But the idea is that we're going to work toward individual well-being. And if you have individual well-being, even in a collectivist society, that means the family has well-being as well. And so, overall, we want to create healthier, safer, and more equitable societies worldwide. So, because when people are healthy and safe, they don't do things like get involved in gangs or in violence. And they're able to go to work without fear of what's going to happen to me on my commute to work or something like that. So the main reasons why we need global health, and they kind of change and evolve over time, but these have sort of stayed pretty consistent. So obviously promoting health and well-being. Nurses already do this, right? So boom, already there. And preventing and controlling infectious diseases. Well, depending on the country that you work in, nurses are often the ones in primary care who are really doing most of that work. And non-communicable diseases. Every country is seeing more and more diabetes, heart disease, cancer. So this is becoming a big scale-up issue for nurses of because a lot of nurses have only been trained to manage, obviously to help to do deliveries if they're nurse midwives, or to address road accidents, or deal with infectious diseases. But in a lot of places, training people in how do we help manage chronic diseases, this is a new competency and skill set. And I'm going to include mental health in non-communicable diseases. And then obviously responding to global health emergencies. I forgot to hit my enter key and get another bullet point there. But with pandemics, because everybody travels now, so pandemics travel much more quickly. I will never forget, right before COVID, I was going to Singapore for a meeting, and they had bought me a business class ticket, and I was like, I'm not giving that up. And this was early February of 2020. So it was really an interesting time because we had been hearing about this virus that we didn't really know much about. And, you go to Singapore, and because they're very orderly and disciplined, have you noticed this? Um, People weren't really on the streets. If you were out in public, everyone was wearing a mask. And so it was very interesting. And then a month later, we were in lockdown. So those are small little things that stick in your mind, right? But if we're going to be able to address all of these diseases, we need strong health systems, and that means we need a sustainable workforce. So one of the things that I like to say is you can have all the interventions in the world. They can even be technology-based interventions. But you know what? They are not going to be able to be implemented unless you have enough people. Many of you, I'm sure, have worked with too many patients. You know what that's like. And so it doesn't matter how many cool tech things that they have. And most of the time, the tech of late has been making more work. It's like, oh, great. My new favorite is some places are doing ambient AI to help with documentation, but it means you have to narrate what you're doing as a nurse. So I am assessing the patient now. I am listening to their lungs. I don't hear anything in their lungs. The patient is alert, awake, alert, and oriented. So you have to narrate that. I'm like, how annoying, And it's like, I can do that same assessment without narrating in 3 to 5 minutes, right? But if I have to narrate, this is doubling my time. And part of the reason is because the tech guys, and it's mostly guys, the tech guys don't ask the users. They're like, oh, this is cool. We want to try this. And they don't test it out beforehand. Yeah, so they're not my favorite people right now. And ultimately, hopefully, our last goal is around promoting health equity and reducing health disparities. Ideally, everybody could have roughly the same health outcomes across countries, depending on what we see. But those are complex things to challenge and tackle and many and multifaceted challenges. So how do we do this? Yes, it's complicated. So collaboration is critical. Collaboration and partnerships, this is one of the sustainable development goals. So you need governments, you need non-governmental organizations, you need international agencies, we need healthcare professionals and their organizations, we need researchers. So all of you who are thinking about doing research, yay, you're going to be in the mix. And we also, of course, need communities. Communities often know better what they need than what we as healthcare professionals think. Because there's data, and that might tell us things, but the community might be like, but yeah, I know the data says that, but what we're actually really need is this. And so the idea is include the community, have all of the voices included there. So with global health, if we collaborate, we can have more breakthroughs that are going to make the world more healthier and more secure. So obviously we need to have knowledge. So if your thesis for your master's or your dissertation, these are contributing knowledge to the world. They're going to help us rule in or rule out different ways of taking care of people and helping their health be better. Technology, again, technology could be useful, but we need to be more engaged in technology creation. And we need to be more insistent with the tech people that we're involved in the technology creation. Obviously, we need resources, but these resources need to be tailored to whatever is needed locally. Not everywhere is going to need the good stuff. Not everybody's going to need the same resources, right? And then capacity building. And so people always ask me, well, what do you mean by capacity building? And I've come to summarize it as I want to make myself irrelevant. So I'm currently working in a country where they suddenly have a lot of money, more money for resources because they now have oil. But they're coming from a place where they've had no money. So all of their records are on paper still. They keep talking about doing an electronic health record, and they've been trying this for 10 years. The nurses, their education, their curricula hadn't been updated for 15 years. So, capacity building can be any facet of that. Maybe it's teaching people how to use Excel, basic things that we take for granted. Maybe it's investing in the quality of K through 12 education. Because if you have a good quality K through 12 education, you have people that are going into health professions that are better prepared, and they're going to do, you're going to have more effective health. You're going to have more effective care that is going to improve outcomes. So it could be any of these things with capacity building. Something small and simple as teaching someone how to use Excel or do data entry correctly, or something bigger like building up research infrastructure, teaching people, developing PhD programs. So, and whatever these are, I mean, it depends on what's needed locally. So, Thailand and Thai nursing is really a leader in this region. And, there has been sustained investment in Thai nursing for a long period of time. Other countries, that hasn't been the case. Now, in some countries, this has been because there was war or conflict, and that decimates your infrastructure. And so you start from scratch again. But other countries, there's more complicated reasons why, why nursing hasn't been invested in. Sometimes it's because it's dominated by women. Sometimes it's because, this social class, there's only one social class that is acceptable to go and be a nurse. And so when you think about all those things, it's working within that existing system, but to build the capacity within whatever that system or culture is. So have you all seen the picture of the Sustainable Development Goals? Oh, good. So this is people sort of underestimate the significance of the Sustainable Development Goals, but everybody in the world, the leadership in the United Nations and the countries all agreed to this. They agreed that these were 17 things that countries could invest in that would strengthen their societies, create healthier people, create more sustainable economies. And here we are. And so, nursing, everybody goes, well, of course, good health. But, nursing also helps to address poverty because you help make people healthier. You help connect hungry people to resources so that they can get food. To have good nurses, you need quality education. So those two things are always connected. Since nursing is still mostly women worldwide, you need more around gender equality. We still see male nurses still make about 7% more in salary than female nurses globally. It's really annoying. And that's even controlling for going into like specialized practice areas or, administrative roles, et cetera. But men also get promoted more quickly, often promoted by the same women who are hiring the same people. And yeah, I haven't wrapped my head around that one yet. So nurses, clean water and sanitation. We see the consequences of when you don't have clean water and sanitation, right? And so it's one area that we can advocate for because we can tell people, say, well, if you haven't experienced not having clean water and sanitation, it's like, well, you can go through that experience, but we can clarify with people they probably don't want to. Clean energy, we see the effects of air pollution, of environmental pollution, and that is caused by how we produce energy for our electricity and everything. So, the clean energy is important for us as much as how we do our jobs and how we work, but also to help people's health. Good jobs and economic growth. There's a new concept out there called economic well-being, which is that people's salaries should put them in a range that promotes their economic well-being, which means they have enough money. It's not just enough money to pay rent and buy food and maybe some clothes here and that. It's that there's enough money to pay rent and buy food and save for something that you want, take a vacation, maybe save enough money to buy a house, those kinds of things, so that your quality of life is actually good. And so because I've never met a nurse who thought they made enough money in any country. I've been to a lot, have yet to meet one. But the idea is that if you can get a nurse's salary into that economic well-being range, then you're overall this is going to help contribute to a country's economy. I got to work with a numbers person on that one, but conceptually, that's where I'm working on. Innovation and infrastructure. Places that innovate, they make progress. There's good to be done through innovation. Reduced inequalities. Like I said, poverty is bad for your health, but it's also bad for a country because poor people, when you're dealing with poverty, they're not contributing to a society. They get desperate, and so they seek things that create their security, because poverty and lack of security, they go hand in hand. So they seek things that create security. So in countries with a lot of poverty, you often see a lot of gangs. And gangs, people join gangs because it offers them a sense of belonging and protection. And sometimes it offers economic security more than what they had before. So that's one example in terms of how do we reduce inequality? Well, if we reduce inequality, we don't have poverty, people are safer. You see the chain. Sustainable cities and communities. So I spent a couple of days in Bangkok before coming here. That's impressive traffic, right? So, if you're spending your life in traffic all the time, and my friends they just moved there, they were living in a country that had a smaller population than the entire city of Bangkok. So it's been a little bit of a transition for them. But my friend, she said, yeah, I can only do one thing in a day because just doing that one thing is going to take so long. So, that kind of traffic doesn't make for a sustainable city, right? So when we're thinking about sustainability, it has to be like, what would what makes that city a place where everyone can thrive? Spending 4 hours a day in traffic doesn't help you thrive. Now, and I imagine like if you're a nurse and you have to go work a shift, okay, 8 hours, well, that makes your day 12 hours. But if you start working 12-hour shifts, I know this is a hot topic. Start working 12-hour shifts, that makes your day 16 hours. So things to think about. Responsible consumption. So this means, if we're going to buy stuff, can it be recycled or can it be reused or those kinds of things? Protect the planet. Well, climate change is real. I mean, we joke, this year where I live, we had the coldest winter. I mean, it was -10 was the high during the day. And we had more snow than we had had in a very long time. And I had friends who lived in the mountain west part of the US. They normally have a ton of snow. They had no snow this year. And they depend on the snow for people to come for tourism. So if we're thinking about how do we protect the planet, it's really about how do we mitigate the effects of climate change. And then life below water. Polluted seas means polluted fish, means polluted food that we're eating. Simple. Life on land, same deal. And then peace and justice. Peace is good. My current administration of my country notwithstanding, but, ultimately working toward peace and justice. If anything, recent events are showing why that's so important. And then partnerships. We can't all do this alone. We have to work together. And nurses can be part of all of this. Sort of find which one makes you passionate. So to get this done, part of this is global health diplomacy. And this is really the policy angle. How do we do this through policy? And I've been impressed. All of you guys are really tuned into policy from our conversations. And so that means your faculty are doing a very good job teaching you about policy. So global health diplomacy, what is this? So it's actually the intersection of public health, diplomacy, and international relations. So this is, the process by which people get together, negotiate, to cooperate, to address global health issues, and achieve global and foster collaboration and achieve global health goals. So, and you have to really be patient if you want to get involved in this field because negotiations, especially international ones, can be very complex and they take time and they don't move as fast as everybody would like because we've gotten so used to instant gratification with apps and being able to get things done right away. It's like, why can't we just do that? Well, the humans still are humans, and so that still takes time and negotiation. So global health diplomacy is this constant cycle. So, we start off with our global governance of health, which is, things around pandemics. It's things like the international performance indicators. So like the Human Development Index, the Gender Development Index, these are all tied to global health. And then it's whatever problem we're going to tackle, it's about negotiation and cooperation. And this is basically how countries work across diplomatic channels. And this is how we're going to tackle pandemics, infectious diseases, health inequities. Increasingly, we're seeing it used as a foreign policy tool. So, many countries were doing international aid investments. And then last year happened, and that whole system was basically blown up. And so, there were always issues with the old system, but you don't just blow something up. You to say, hey, we're going to shift how we do this. We're going to make changes in ways that are not devastating to the people who are being funded by these things. And because that does not foster goodwill, which is part of what diplomacy should do, is foster goodwill. And, it will require multi-sectoral engagement. So, you have to talk to governments, international organizations, private sector companies, civil society. So the country that I'm working in, we're funded by the government and the Ministry of Health. We're funded by a foundation that comes from an oil company. And we're funded by other philanthropic sources and the Department of State. And, part of this is to address part of the work that we're doing is to address the critical shortage of nurses. So they graduate, well, historically, they had been graduating about 100 nurses a year, and then they were losing 200 nurses to migration. So you can't really keep producing and sustaining your health system if that keeps happening. So what we're working on is, well, one, first you look at how do we produce more nurses? So that was our first step. And now it's like, well, how do we retain them? Now, fortunately, the pay has been increased. The nurses there were making $400 a month, right? I'm like, that was in terms of regional averages, that was 50% lower than, no, 60% lower than the regional average. Yeah, I know, right? So the government doubled their salary, just slightly more doubled than their salary to $900 a month. Are you feeling better about local nursing salaries now? Yeah. Uh, but even though the government doubled their salaries, the cost of living has gone up because there's all these people coming in from abroad. And so all the international people, get charged. There's the international price and then there's the local price, but it still means the cost of everything is going up. So you have to have these partners, and we work with the local nursing council. They're our civil society partner, and we're the international non-governmental organization, for lack of a better description. So, but we couldn't do this without the partnership, and we had to earn that trust. Like we had to be able to demonstrate, what we could do could actually produce and make changes and make a difference. And so, the first 3 years we worked there, we spent our time proving. Now they've decided, yeah, we like working with you guys, so we're keeping you, which is good because I'm enjoying the work. So, and then one of the other parts of global health diplomacy is what happens with conflict resolution and humanitarian assistance. What happens when there's a famine somewhere, or there's a massive, natural disaster like a monsoon that washes away villages, coastal villages and communities. And so how do we get critical aid and medical care to these places? Because oftentimes local response systems aren't enough, and but the international community can go in and help. So this is a constant ongoing cycle. It's not necessarily always happening in this circle, but these are the core components of it. So if you these are some examples of some international policies of that were the result of global health diplomacy. So how many of you are familiar with the infant formula ban that happened in the 1970s? So, this is again, always be careful of the corporations. So, corporations that made formula were selling formula and selling it to countries where they didn't have clean water, but they didn't tell people that you needed to have clean water to feed babies the formula. So, for about a 20-year period, we saw massive spikes in infant mortality because mothers were feeding their babies with this new modern way instead of breastfeeding, and it was causing massive deaths of babies. And so the world came together, and this was one of the first international bans of a specific product, saying you cannot sell infant formula in a country that does not have, where people do not have access to clean water. But it was also became one of the drivers of the push for breastfeeding. 50s and 60s, they had, because of modern inventions and things like that, the idea was, oh, breastfeeding, it's so old fashioned. I'm like, well, it's kind of worked for several millennia, but, humans like trends, right? So infant formula ban, that was one of the big ones. And then with AIDS coming along in the 80s and 90s, but also the ongoing issues with managing tuberculosis and malaria, the world came together and said, we're going to create a fund to fight these diseases. And so that happened in 2002. And then tobacco control, when we finally, every nurse who ever took care of a patient with lung cancer could say, yes, of course the smoking caused it. But, it took decades of research to really show and demonstrate that causality. And so the tobacco companies had to pay into this fund so countries could recoup the costs of people smoking. It's fascinating traveling to places. So many countries, it used to be, wow, there was smoking everywhere, but it's just really gone away. There's only a select few places where smoking in public is still really, really common. I mean, I was going out as a young person in New York City, right before New York City banned smoking in bars and restaurants. And this was like 2001. And, it was the usual thing. You'd go out, you'd come back, and you'd stink of cigarettes, and and it would be in your clothing, and then you'd have to send everything to dry cleaning. And then 2002, it was like going out and was like coming home. I was like, wait, I don't stink of cigarettes. Oh, wow. And, the dry cleaners were a little upset because, their business got cut. But yeah, these are things, the little things, around why these global actions start to take place. And, the health implications. I mean, every disease caused by tobacco and smoking was costing health systems billions of dollars. 2010, ethical recruitment of health workers, still an ongoing issue. A lot of countries were adhering to this after the pandemic. They were like, yep, good to go. Don't want to, we're going to go back to recruiting again. And, this is still a problem. And, it's not being addressed the way it needs to be. Now, you can mitigate these things. So for once, the US is not the bad guy on this one, because we have an exam, a licensure exam. And if you can't pass the licensure exam and you can't pass the English proficiency, you can't come to work. You can't get the green card to work. So, that means that our numbers are definitely very specific in terms of who's able to pass, and not coming in large numbers from countries with critical shortages. COVID-19 vaccine diplomacy. You saw there was this tendency of countries with resources were going to hoard their vaccines, make sure their populations got vaccinated first, and countries that didn't have resources weren't getting that vaccine. And the World Health Organization said, yeah, no, that's not ethical. And so insisted that the vaccine get out there. And then most recently, we have the Pandemic Accords, another historic agreement. So this is basically, goals that by World Health Organization member states that they created for every country. They set targets. Basically, here's what you need to do to make sure your country is not as shocked by the next pandemic, because there will be another one. We don't know when, but we want to be more prepared for it. And so during the pandemic, I started a multinational research consortium. We have 87 countries. We have data from nurses, from almost 15,000 nurses worldwide, and mostly low and middle income countries that documented the effect of the pandemic. And now what we're doing is we're taking that data and we're showing, here's how you need to invest in infrastructure, and here's where, and here's examples of why. Because this happened to your nurses. So if this was happening to your nurses, this means you're vulnerable in this area. So when we're strengthening health systems, again, I'm going back to the collaboration things. So, health systems that work well keep people healthy and working, but health systems are complicated, right? You've all observed that. They're all complicated. It really doesn't matter the country. Because people are complication people are complicated, organizations are complicated. But if you have a strong health system, it means your emergency response system is easier and fewer people die. And health systems help people thrive and experience well-being, which means that they can go to work if they want to, they can stay home and take care of kids if they want to, whatever they want to do. But the idea is that they're healthy and they can have that choice. When you're not healthy, you don't have that choice. Obviously, we want to prevent the spread of pandemics, and should there be a bioterrorism incident, it will reduce the likelihood that there's going to be, significant impact. So every country has some common challenges that they're facing for global health, and you're probably seeing this in your own practice too. So, my slide was on my thing was, the words were right, but I hate that when that happens. Okay. So diseases and health challenges, staying healthy. Every country needs to do that with their population. Everybody's got a different disease profile. There's stuff here that, if that happened in the US, I'd be calling you guys and being like, we're seeing this. You guys have that. What do we do? And, diseases, they're really annoying. They don't recognize borders. They don't go through immigration control. They don't get their passports stamped. So, you have to have a disease surveillance system to be able to respond to pandemics and protect populations. And then also we have a humanitarian responsibility to help others during a crisis. And, this is part of our moral and ethical obligation as professionals. If we don't have a code of ethics and a moral duty, then we're not a profession. So these are things, and, these are things that people sometimes forget, I think. So economic and social stability. So if you invest in global health, you have healthier, more productive populations. I've said this a lot, but sick people cannot work. If people cannot work, they cannot contribute to their economy. Economies cannot grow if people do not work. And because of poverty creates this lack of security, it increases the risk for violence and leads to less stable countries. Now, I will tell you that it took me a long time to summarize it into one slide. But, when you share this with people, they're like, yeah, that makes a lot of sense. Why don't people talk about it that way? Climate change. There are so many unknowns, and I'm not even going to go through all of the detail on this slide. You will have a copy of the presentation. But, how the weather, the air, how bugs create and reproduce, allergens, water quality, water and food, environmental degradation, all these extreme heat. It's warm here in Thailand. It's my first time here. It's a little warm. And I know I'm not even in the hot season. My understanding is there's, hot, and then there's really hot, and then there's really, really hot. are the three seasons. So, um, yeah, so the heat's not good for your brain. Like the more research we're seeing, it's like, yeah, heat fries your brain. So that's not good. Equity and justice. So these ethoses of equity and justice is that we should help people is that everybody should have the right to be healthy without, if while controlling for genetics, if you genetically are predisposed to high cholesterol, okay, not much we can do there, but we should have a solution to help keep your risk for other heart disease issues from that high cholesterol be available. And so, when we know that there are health outcome differences between groups, and when you have universal health insurance, that really helps. That really helps reduce health differences between social groups. Now, the trouble is sometimes when you implement universal health insurance, all of a sudden nurses see way more patients coming into their health systems. And, and the old ways were, the finance models often don't catch up with the policies. The number of times where the Minister of Health, said, yeah, we can, or the Minister of Finance said, yes, we should invest in producing more nurses. And so they produce more nurses. And then the Minister of Finance is like, yeah, but we don't have money to hire them. It's like, okay, we need to be working on that a little bit more. And, part of equity and justice in countries is that everybody has access to all the things that are in that right-hand column. So when we're working toward those, and nurses help contribute to all of this just by doing what you're doing. So it's not like this is something extra that you need to do. This is something that you're already doing and contributing to. Migration is affecting everywhere. And human migration has definitely returned to pre-COVID-19 pandemic levels. And when you have immigrants coming into your health system, this presents, a lot of unique challenges. Language barriers, my favorite issue. That's the first one. And that has huge impact on nurses. But we don't really have standardized ways of dealing with language barriers. And I'm working on that. That's my other line of work. But, and how people access a health system in their new country is going to be reflective of their experiences in their old country. So, when people come to the US, we have lots of nurse practitioners and physician assistants. But we have a lot of people that come from countries, they have no idea what that role is because that role doesn't exist in their country. So, and their expectations, especially around nurses, can be shaped by their previous country experiences. A colleague from the UK of mine works as a midwife, and she was telling me a story of, UK has many people who have come to migrate and live in their country, including nurses. And so there are many midwives from Africa that are working there. And so she described a situation where the African midwife, who is very well respected in their home country, but she had a Bangladeshi patient, and the Bangladeshi patient didn't have any respect for midwives. Doctors did all of the deliveries in Bangladesh. There weren't midwives. Midwives were for poor people when you couldn't afford a doctor. And so she did not treat the African midwife very well because she did not, her cultural background was that was not who she should be attending her birth. So, these complex, and you can imagine how that situation went. But you can imagine these things complicate our care delivery when we have to understand where are people coming from and how do we meet people's needs. Now, ultimately, the head nurse came in and said, well, no, everyone is attended by midwives here. And so, you will be attended by a midwife. So Global Health 2.0. So Global Health 2.0 is sort of it was sort of like because of the late 20th century, early 21st century global health movement, that was sort of considered 1.0. Some people argue that, it's actually more like 4.0 if you take into account the whole history, but 2.0 sounds good right now. So Global Health 2.0, I'm sort of summarizing it as moving away from what did not work. So the idea of many people had started talking about efforts in global health as another form of colonization, of people coming in and saying you need to operate your health system this way, or you need to do your job this way because that's how things work, without recognizing local knowledge, local experience, or taking an approach of how can we develop a locally appropriate solution. And the idea is that we move toward this one health approach where everybody should have the same quality of health. And of course, there's digitalization and AI that's going to either make our lives better or more complicated. I think the jury is still out on that one. But the other thing is local production. So, one of the things that COVID made clear was the lack of vaccine and local production for medications and treatments became a real problem when the supply chain logistics fell apart, or when the demand, were drove up prices, did those types of things. So when we're thinking about those things, it's how is how is your country prepared locally? Can you make your own masks? Can you make your own medications? Or, if you're in a region that's a reasonably, large size, does it make sense for you to partner and have a regional partnership to be able to produce and share these things? And what we're thinking is for the next 5 years or so, there are these structural disruptions. So structures are the things that sort of the physical and operational and political aspects that make a health system work or not work. And so 2025 basically disrupted everything. And so, because of these disruptions, the idea is, well, can we help people move toward being less dependent on international aid? A lot of investment has been made in building capacity. How do places move? How do they move on? And can they function independently? And they should function independently. And if they are not functioning independently, then we weren't doing a good job before. And the other thing around reshaping global governance, the UN and the World Health Organization, they have a lot less money. They're cutting a lot of programs, they're changing how they operate. And we don't know what that's going to look like. We may regret that, or maybe it was time. And and then the power dynamics, they're talking about international aid being reduced by like 70% over the next 5 years. And that's a huge amount of money. But where does that get replaced? How does that get replaced? Should it get replaced? And the idea is that leadership in countries, no matter where you are, should really take the lead in advocating for what they need. But the question is, will those needs be met? Do the international systems recognize that those needs need to be met? Improve self-sufficiency. The idea is that there's less dependent on external money coming into the country, and that the country's economy can support what it needs. Yeah. Oh, you've got all my notes there too. Okay. Um, and other trends, boy, that again, I hate it when the thing changes your text. So decolonizing and improving data infrastructure. My example of the other country that I'm working in, so many countries still have all their records on paper, especially for nurses, because, even though we're the most, we are the last to be thought of. That also needs to be changed. Bilateralism over multilateralism. The idea is that countries, that want to invest in another country, that they make that these are, just agreements between the countries instead of regional operations. AI enabled healthcare. Yes, that's going to be a trend. Is that going to make healthcare better? We'll see. My most recent thing that I saw is, so if you have an quote unquote AI nurse, what happens when that nurse makes a mistake? Because the AI still hallucinates. I was putting together another presentation this week and the AI completely hallucinated a solution. I was like, there was not one mention of this in the data that I fed it to help me generate the presentation. And it just hallucinated the solution. I was like, well, so we will be taking that out. And then obviously climate change, because climate change is going to increase the number of patients we're seeing, both in primary care clinics and in hospitals. Future challenges. Part of me is sort of like, well, these are future challenges, but these are challenges that have always been there. So the financing gap, how do we pay for all of this? Scientific integrity. So how do we make sure that the research that is being produced is actually good quality? The proliferation of these predatory journals. Well, hey, you can pay me $2,000 and I'll publish your paper in 10 days. It's like that has really compromised research and, but you also have a lot of people that unwittingly get caught up in these journals and end up publishing, and they don't realize that it's not going to make a contribution to the evidence. And then geopolitical conflict. There has always been geopolitical conflict, but what that looks like, we shall see. So, summary. Hopefully you got the message. Global health is for everyone. And, even if you're just doing what you're doing as a nurse, you are contributing to global health. And, but we're working together to make a better place in the world. And, hopefully we're doing this through international collaboration. In my consortium, we have a lot of countries. They have tensions between their two countries, but in the consortium, we don't have those tensions. Because the idea is, no, we're working toward making everybody healthy. And like I said, when you work locally to improve health, you are helping to improve global health. So maybe you'll travel, maybe you'll go to other places, maybe you've already done that. But, pay attention around you, that nurse sense, see what's going on, and then see, maybe you can help. You never know. But if you'd like to email me, if you have any questions, please feel free anytime. I travel a lot, so sometimes I'm a little delayed in responding. Any questions? Folks online, any questions? Not used to sitting down when I present. Normally I'm up walking around, so count on that to get my steps. My super helpful friend Tanawat's there. Any questions? All righty. Well, thank you all. Thank you all online for coming. And I'll be talking this afternoon about how to write a paper for an international audience. This is one that this was a therapeutic editorial that I wrote because, there was a lot of good research coming in, but it was written like, well, of course we know what your health system, of course you understand our health system. I'm like, no, I don't. And we want to get more, people need to understand what's going on elsewhere so they can see, oh, that's a good idea. We have a question from Korawit. So thank you for the insightful lecture. I found the role of AI in global health very interesting. However, given the unequal access to technology across countries, I was wondering, to what extent can AI truly reduce health disparities rather than reinforce them? Great question. And, that issue, it's interesting. So before COVID, hosting an international meeting was really challenging on Zoom because people's internet infrastructure wasn't great. But for whatever reason, for all the important reasons, like everybody had to work at home, countries' internet infrastructures just improved dramatically. So I can have conversations with colleagues now in countries that have historically not had great internet access, and we can have meetings and there's no like connection interruptions or like, sorry, what did you say? You know, unless they're on their phone in a car, but that's one of those things. So, um, I think the there's no easy answer on that one, Corowit, because I think AI could actually reinforce health disparities because it's all about who has access. At the same time, it could create more because again, it still hallucinates. And who's accountable for the error? Is it the software company that's been programming AI? It's like, that, that nurse that's an AI nurse, that nurse hasn't passed the licensure exam. It's never talked to a patient. So it's an interesting one. I think the jury is still out and it's something, but these are the ethical questions that we have to keep asking because that's the only way we can hold the tech companies accountable. They have no interest really in making the world better. They just want to make money. This is my conclusion. Very, very few actually have an interest in doing good. Oh, yeah. Yeah. Yep. AI can make you crazy. So I find AI useful for a few things. I'm terrible with paper or grant titles. So I just to ask it, I'm like, give me some grant titles. Give me a good acronym too. You know? It's good for that. It's good for creating forms. So if you're like, I need a competency checklist based off of these standards, can you make one? So it gives you a starting place. It formats all the tables. You don't have to worry. It's lovely that way. That I love it for. But it can't analyze qualitative data unless it's specifically programmed to do that. So ChatGPT, Claude, Gemini, not useful for that. So lots of limits. It will. You can ask it to write code for your statistics, though. Which I was like, well, okay, that's a perk. Now, I personally don't like programming stats. That's my husband he's a math PhD and he finds it relaxing to sit down on the couch and program stats. I'm like, go for it. Not me. But I was like, well, yeah, programming stats, that would be useful. So yeah, I think again, the jury is still out on AI. But yes. Mm-hmm. Mm. 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 Great question. So for the folks online, this was a question about, our colleague has interest in nurse well-being, but it recognizes that well-being is multifaceted and can be caught. There are a lot of different factors that can contribute to that. So I think so in my the study we did during the pandemic with nurses, we asked them about self-care. And we said, what are you doing for self-care? And we phrased self-care with your classic, we had one question block that was all the things that are known to promote health. So, exercise, sleep, eating healthy, talking to friends, getting support, doing whatever. And, for the most part, nurses knew how to do all of that. But we also then asked them questions about other self-care methods, which were around substance use to really understand, well, who's using alcohol more, who's smoking more, who may be using drugs, and doesn't matter if it's legal in your country or not, people will still get it. So, because of that, so it was interesting to see those patterns. So I think the assumption is first that we should not assume that nurses don't know how to take care of their well-being, but we need a better way of identifying the people who are struggling. because nurses are very good at hiding it because of all of the stigma around mental health. And so I think when we're looking at those factors, we have to acknowledge what are the factors we can change to help promote their well-being. But it may be the solution is more around if there are factors we cannot change, how do we help people cope better? And because there is productive coping and then there's non-productive coping. Yeah.
So the complex background so overly I think different with the Western countries.
Mhm.
So I like it like some confucianism.
Mhm.
Yeah.
Mhm. Yes.
So I think it's really difficult to change anything.
Mhm.
Sadly. I think the better.
Exactly. So that she had observed around in China issues in tertiary hospitals around organizational culture associated with the cultural aspects of Confucianism. And so literature that might be helpful for you to read is literature associated with organizational studies because organizations they kind of function, they're made of people and they create hierarchies, they create bureaucracy, there are things that happen within them, but you can set a culture that would align culturally and be one that would promote nurse well-being. But what that looks like, I mean, I know there are people working on this, but it's a challenge. And especially it's also a challenge when the organization and the culture has a significant gender component. Yeah, where there are gender expectations around submission or behavior or speaking up, expressing your voice, your opinion. But all of the research that we know, including research done in China, shows that when nurses are involved in decision making, the work environment is better, their well being is better because they feel like they have a say. Mm-hmm. Other questions? All right. If no more questions, I know this was booked for 2 hours, but hey, nobody's upset by found time. Whenever you run a meeting, your goal should be to give people back time. All right. Uh, I don't. I guess we'll leave the meeting. I don't know if it's still recording. There we go. All righty. Well, very good. Well, thank you all for coming. It's always nice to actually have people in the room when you present. My pleasure. Where do you hail from? Oh, from Lebanon. Great. How did you end up here? That has to be a good story.
And I was coming for my friend's wedding
Mm-hmm.
in Bangkok, and war happened in Lebanon at this time. So it was safe. Like my father was happier for me to stay here, don't stay over there because the
Yeah.
cities now.
It's not good.
Yeah.
Yeah.
I hate to say it, but the war is much too good.
I know. Yeah. I think we all know that.
Also, my wife she's Thai, so I stayed.
Ah.
This semester. And over here, I cannot work because I don't speak Thai.
Yeah.
So the best thing to do is continue my education.
Yes.
Yeah, and I love knowledge. I love to see. I'm kind of person I seek knowledge. I love knowledge. So
you're doing your PhD?
now master.
Now masters. Oh,
That's postgraduate. And my background is American standards since I worked at the American University of Beirut. And then I traveled to Qatar. I worked with the medical was Northwestern medicine. Northwestern medicine, we know about them, of them.
Yep.
So they are in Chicago.
Yep. Yeah, we have a PhD student from Lebanon. She came 4 years ago. She will graduate this year. She also worked for American University Hospital in Beirut. Her name is Mireille Chehad. So, I mean, you never know. Sometimes it's like a small town. New York University. We are still taking international students. And my university is very good at working the international channels. So, and we offer 4-year scholarship. It's now we give a living stipend, but New York City is very expensive. So it's not much.
Actually, what we studying acting.
Mhm. Yeah.
Still going to us. It's my like to-do list because you know in us the nurse is more respected. Look, I come from a family, my uncles are most of them are like doctors.
Yeah.
And when my father told me in front of my uncle who's a doctor, told me like my father is pushing go for nursing because he knows there's shortage. I
Yep.
always find a job and like this. And my father is smart about this. My uncle is a doctor. And they told me he wants to be good.
Oh, right. Because that's all we do, right? Yeah, exactly.
I still had it. So I was doing banking and nursing together, and I chose nursing. And thanks God,
Oh, yeah.
yeah, and I love
Yeah.
it.
You kept your soul.
That,
Yeah.
but it's don't like that.
Yeah.
It's hard.
It is. But it's, we're often invisible. And, people don't see us in the media. They don't see us on TV shows. Or if they see us, like everybody's seeing Grey's Anatomy. Yeah, right. Where are the nurses? Like, come on. Yeah. Yeah. Not enough visibility so that people don't actually understand what we do. Oh, yeah.
Patients, and patients, they tell me thank you more than that because I really do the best. But the still, worldwide, they don't see us.
Yeah. What one thing you could do while you're doing the masters is also get trained as a medical interpreter. Yeah, it's actually there's a huge need for medical interpreters worldwide. And it's another if you study internationally, it's another way to earn money on the side.
I think thanks.
Yes, and you already have all of the medical vocabulary, so that makes a huge difference. Most medical interpreters do not have a clinical background. Yeah. Yeah. Yeah.
You see about something about the nurses salary.
Yeah. Oh, which country? It's a country that I'm working in right now. I don't want to disclose because, yeah.
Salary. But give me more money. What I'll give you more.
Right. Right. But right. The salary also, I mean, this is why I push the idea of the salary needs to be for economic well-being. Can you support a family on a nursing salary? What's interesting is in the US, when the nursing salaries hit a certain level, we started seeing more men come in because you could support a family on a nursing salary. Mm-hmm.
Most of my friends used to work at A, B, and C. They are
Mhm.
now as not in nursing.
Yeah.
More than 11.
Yeah.
Salary.
Well, the salaries, there's a few other things going on in Lebanon that
Yeah.
don't help either. Yeah. Yeah. Do you know Professor Nuhad Dumit?
Yes. But yes, of course.
Yeah. She's my Lebanon partner for my consortium. Yeah. Yeah, I love her. She's amazing.
I used to work at
Yep.
She was American University.
Yep.
My father graduated.
Okay. See, this is where nursing becomes a small world after a bit.
And I heard that they will change the naming format. And I want to know the concept about diversity because
Mm,
your previous lecture is about a multi or cross cultural. And I want to know that our responsibility or our duty that relate to the nurse that we do for the diversity and cultural.
yeah. So the diversity and cultural piece is understanding where people come from. The easiest way is food, right? So obviously you don't want to give a Muslim pork, or seafood. Same thing with a Jewish person. And, we know that in Asian culture, with certain illnesses, you have to eat foods that have a certain temperature, right? Or they're perceived as a hot food or a cold food, depending on the stage. So it's the idea is that it's not that you have to memorize like, oh, don't give this person this or give this person that. It's not that. But the idea is sort of bigger picture around recognizing that people's experiences and how that shapes it will influence their identity may influence like their inequalities. So if we're seeing more and more research that shows that people who are discriminated against, they actually have cellular changes at the DNA level that shortens their life. Because that constant stress of running into discrimination, having those experiences, the negative effects, no matter your mindset over time, that cumulatively has effects on your health. That's what it means. So it's the idea is sort of being culturally humble because, for example, the public hospital across from my nursing school. So the first slide there was, the picture of my nursing school and the public hospital across the street. They have interpreter services in 69 languages. Can you imagine? So one, you can't be culturally competent in 69 languages, cultures, whatever. And so there's no way to be competent, but you can have an attitude of, okay, oh, I'm going to learn more about you. What do you need? So part of your assessment is, what do you need? What will be comforting to you? If you need to have a little house of the spirit in your hospital room, if that's comforting to you, great. Okay. A good example is pediatrics. So some cultures, you never leave your child alone when they're sick, but some hospitals have outdated rules about parents staying. So, the idea is that that's one of the things that you can do is you can say, no, this is really important culturally. You can advocate for the patient. Yeah. Oh, yeah. It's a big topic, but it's understanding how aspects of a person's identity, when you have a very diverse society, aspects of a person's identity are going to change their health outcomes. And I mean, you might even, and again, I'm still learning about Thailand, but there may be different communities that because of historical aspects of their identity, maybe they're not as healthy as other communities. If you think back to your home countries, you may see that too. And these are things where to an outsider, everybody, it's like, well, no, but you're all Thai. But no, no, no. There are cultural things that we may not be familiar with as an outsider. So the idea is, how do you go into that situation with the idea that you can respect anybody, but also respect their culture and their needs? No problem. My favorite example of that actually was an interpreter situation where there was an interpreter that was needed for a Chinese dialect that was spoken by just this one little village in this one part of China. And people had immigrated and they were in the US. And so they miraculously found an interpreter who spoke this dialect in the first place. So they brought him in. And then it turned out that the person he was interpreting for was from a rival village in the same place. And this created a whole set of tension, between them because they were rival villages that had family history issues that went back, hundreds of years. And like as a nurse, you're like, okay, there's no way that I could have anticipated that. But, then it's like understanding, reacting to that situation, which is, okay, please, let me help me understand this situation. But also like if it's a really not commonly spoken dialect, you're kind of, you got a challenge there. But that's a culture, that's a situation where there's culture, there's history that you maybe can't anticipate. So then you as a nurse, how do you handle that?
Of that the majority. So
Mm-hmm.
understand the even the living in the
Yeah.
community, they have a different country.
Yeah. Yeah.
Sometimes we don't understand the standard language we can use. We can
Mm-hmm.
ask some the local officer to translate for the
Mm-hmm.
something with the hospital.
Yeah. Yeah. Completely important. Universal issue. And, but in the US, most people are like, oh, well, don't they speak like Mandarin or Cantonese? That's all they know. In New York City, because we have Chinatown, then we get a couple of other dialects. So I hear Taishanese, Fujianese, Fukienese, Hakka. Those are the four that I've heard. I'm sure there's more.